next speaker is Professor Peter Rowe. He's at Johns Hopkins University and has written, like Professor Gray, many of the seminal articles on dysautonomia and the importance of postural orthostatic tachycardia syndrome, neurally mediated hypertension, and the cardiac side of hypermobility syndrome. And he's found a correlation between this and Ehlers-Danlos syndrome and myofascial syndrome, and has done a lot to sort of unify these medical conditions with what we know about the genetic condition. So Dr. Rowe is one of the pioneers in the United States on this whole subject, and it's a great honor to have him here today.
Thank you. Thanks, Fraser and Dr. Patel, for hosting this. Just as a connection with the previous speaker, as I've started in my work on hypermobility, the benchmark review articles and the major guideposts for looking at joint hypermobility were Dr. Graham's papers, so it's a pleasure to follow him. I was asked to talk about cardiovascular manifestations, and I'm not a cardiologist, so I'm going to limit what I say to the thing that I know the most about, and that's orthostatic intolerance and the various syndromes that we see quite commonly across the range of disorders that Dr. Graham was discussing. I don't have any financial relationships, and what I thought I'd do is begin with a representative case, look a little bit at the pathophysiology of orthostatic intolerance so that we're all on the same page, and then the evidence for its co-occurrence in people with EDS and joint hypermobility. So the first, the patient I wanted to present was actually a very capable young woman who'd been an aid worker in Tibet. She was a very highly functional young woman, entered medical school at Johns Hopkins, and started to have problems. She started getting fatigued. She had unrefreshing sleep. She couldn't exercise, lots of aches and pains, and cognitive dysfunction. Some people have suggested that was related to the quality of the lectures in the first year, but I deny that completely. When you looked at her past history, she had been having problems with recurrent fainting since she was 11, but they were fairly infrequent, maybe 2 episodes a year, and it was usually in a typical situation where she was in an upright position for a long period of time with a heat stress, such as a hot shower. The interesting thing that made your ears perk up about joint hypermobility and connective tissue problems was that she'd had frequent knee dislocations, and it had 4 spontaneous pneumothoraces that eventually responded to a pleural procedure. But once she started in medical school and was sitting all day, she got much more lightheaded. So she went from 2 syncopal episodes a year to 2 episodes of near fainting each week, and she was lightheaded several times a day whenever she'd stand up after a lecture in first year. And she noticed this interesting overlap that she was much more tired after a syncopal spell. And that had actually been described back in the 1930s by the person who first defined vasovagal syncope. At any rate, she was seen by the Hopkins University Health people, and they thought she must have, with all these symptoms, atypical depression. And she said, well, I don't think my mood is a problem. I think I'm just really dizzy and lightheaded and tired, but agreed to try sertraline or Zoloft. And usually that drug actually helps in these conditions. In her case, it didn't, and she was worse. So as a result of all of these symptoms, she had to repeat her first year of medical school. And that was the first time she'd ever had that kind of level of failure in her academic career. One of the things that people noticed about her, and that we see very frequently in the EDS and hypermobility population, is this dependent acrocyanosis that you can see on this slide. Here's a young woman who had had to drop out of college. This isn't her picture. And I had her stand against the wall, and this is my hand as a comparison of the color. And this is after 3 to 5 minutes. The other thing, for those of you who spend any time in the ICU, that's interesting is here's where I put my fingers against her skin to test her for capillary refill. I then stepped back, picked up her cell phone camera. My son will tell you I'd be the last guy that he would trust a cell phone camera with. I fiddled with it, finally figured out how to take the picture. So something like 5 to 7 seconds later, there's no capillary refill. And if those of you who are neurosurgical residents saw this in your ICU patient, you'd be starting a dopamine drip or getting the intensivists involved. So this is something we see with great frequency. We then thought, let's investigate her lightheadedness and syncope with a formal tilt test. So we had her supine for about 15 minutes, then she went up to a 70-degree tilt. The tilt was supposed to go on for 45 minutes. She had a very mild 9-point increase in her heart rate, was immediately lightheaded and pale and not comfortable. And she lasted only about 5 minutes. And at the 6-minute point, she had this sudden plummeting of her blood pressure, and the heart rate dropped. Normally, as we see in the ICUs, if somebody's getting septic or they're hypovolemic, their heart rate rises tremendously as blood pressure drops. But this pattern was characteristic of a vasovagal, or we call it a neurally mediated hypotension response. She even had a couple of seizure movements as the table was brought down to the supine position, and she then recovered afterwards. We treated her with one of the medications that's available now for recurrent syncope, midodrine, which is a peripheral vasoconstrictor drug, and we also increased her sodium and fluid intake. She had been noted by our tilt table staff to be hypermobile. So she also went to see the geneticist who looked at her echocardiogram, and she had a normal aortic root and just very mild mitral valve prolapse. So the genetic diagnosis was Ehlers-Danlos syndrome. And so she was doing a little bit better, but she came back to me about a year later and said, look, I'm really having this persistent non-cyclical, meaning not just with her periods, pelvic heaviness and low back pain with standing. So she said, I'm really worried about my ability to be upright during the surgical clerkships. So around that time, we had been working with one of our interventional radiology colleagues, Tony Van Brooks, on a problem called, used to be called pelvic congestion syndrome. And these were women who were often very fatigued, had low blood pressure, and were generally thought to be psychosomatic and emotionally frigid, because one of the problems they had, in addition to the pelvic heaviness that was worse with periods of standing, was that they had terrible discomfort with sex, so dyspareunia. The pain was distinguishable from endometriosis because it was typically worse at the end of the day. It would be worse with the periods, but also was there throughout the month. And these patients have fatigue, bladder urgency, and a very strong association, it was finally determined, with varicosities in the ovarian vein distribution, which have an uphill climb from the ovaries to dump into the renal vein. And over time, things changed. Once the radiologists started doing venograms, they noticed that the varicosities, they could plug them up, and after transcatheter embolization, about 90% of them have an over 80% relief of their pain. So this is a treatable thing. It's probably more common among those with EDS because of the early propensity to varicose veins, as you heard about from Dr. Graham. And to show you what her venogram looked like, here's the catheters coming up, snaking over into the left ovarian vein, and their dye is injected, and you see multiple channels that shouldn't be there, tangles of vessels. There's reflux of the contrast past the midline, filling the right ovarian vein. And the radiologists then put in these little coils and sclerosing agents, and this is the post-embolization film, and all you see is contrast in the ureters. So how did she do? Well, she had a marked improvement in her pelvic pain and her orthostatic symptoms, interestingly, after the embolization, and had no further syncope. She was able to stand for 7 hours during her surgical clerkship, and the most amazing thing was the cognitive change. She wanted to be a surgeon at that point, which, depending on your perspective, either indicates a marked improvement in her cognitive function or something else. All right, so let's unpack the orthostatic intolerance piece of that. This is a cumbersome term. It is meant to apply to a group of clinical conditions where symptoms worsen when we assume or try to maintain upright posture. And those symptoms tend to improve but aren't always abolished by lying back down. The main physiologic challenge when we stand is that we dump about 500 to 750 mils of blood in the lower half of the body, including, and not well shown on this cartoon, including in the splanchnic circulation, which may have implications for the kinds of GI motility symptoms that Dr. Graham mentioned. Normally, in response to that amount of blood in the legs, we have a little bit of a drop in arterial pressure. There's less stretch of the arterial baroreceptors. The cardiovascular centers in the brainstem then increase sympathetic nerve outflow, which is intended in part to bump up heart rate a bit, 10 to 20 beats for most of us. And the biggest change is this huge surge of sympathetic activity peripherally that leads to release of norepinephrine and better vasoconstriction, so that the blood is then mobilized back up to the heart, and most of us can stand and give a lecture or teach in a class for as long as we feel like it, or until people fall asleep. If that process is not working, these are the symptoms you can get with orthostatic intolerance, and they look like they occur all over the body because that's where autonomic function is needed. So the symptoms on the left are typically the ones we associate with a reduction in cerebral blood flow. So lightheadedness, poor concentration. These patients often feel as if they've suddenly acquired attention deficit disorder. They can get orthostatic headaches, blurring of their vision. And most people with orthostatic disorders have some degree of fatigue and exercise intolerance. The symptoms on the right, generally but not exclusively, seem to be due to an increase in adrenergic activity in response to the pooling of blood in the limbs. So there's an orthostatic shortness of breath, chest pain, palpitations, tremulousness, some of the anxiety you heard about, sweating, and nausea. This slide is meant to show you two of the common forms of orthostatic intolerance. This is the patient I showed you earlier who had the neurally mediated hypotension. This is synonymous with vasovagal syncope, neurocardiogenic syncope. The problem with using syncope in the title, though, is that not all of the patients have fainted. So we prefer the term neurally mediated hypotension, or NMH for short. POTS is probably more common, and it's certainly being recognized more commonly because it requires a much shorter period of orthostatic stress, 10 minutes. And we define it in adolescence as a 40-beat increase in heart rate from supine to 10 minutes of standing. It's a 30-beat change that's required for adults, or in either group, a heart rate above 120. But it's not just the heart rate criteria. You have to have reproduction of the orthostatic symptoms, and you can't diagnose this in somebody who's acutely dehydrated with diarrhea or who's had blood loss. Usually these symptoms have been present for a while. To summarize the main pathophysiologic features from a lot of the physiology literature, these patients tend to have some problem with either excessive pooling of blood in the periphery or a defective ability to vasoconstrict. It's not fully understood. Many have about a 10 to 15% reduction in their intravascular volume, so they're always functioning at a hypovolemic state. When they then add an orthostatic stress, and that can include just sitting for long periods of time or standing, they get a marked sympathoadrenal increase. And David Goldstein at the NIH has characterized this in a way that I think is helpful, and that is that if the main response to that is a huge increase in norepinephrine, that tends to preserve blood pressure and increase heart rate, so they get more of a POTS phenotype. If there's more epinephrine release from the adrenal gland, that tends to be a skeletal muscle vascular bed vasodilator, and people typically have more hypotension. The literature describes these two conditions almost as if they're entirely separate, but in our experience, it's not uncommon for somebody to have POTS in the first 10 minutes of the tilt test, and if you continue keeping them upright, their blood pressure will fall. The good thing is that the treatments for the two disorders are almost identical. So we use Vasoconstrictors like midodrine, as you heard about, methylphenidate and some of the stimulants can be very helpful here. Volume expanders like fludrocortisone, the increased salt in fluids. Sometimes birth control pills seem to have a useful effect on expanding volume for the girls. And then low doses of beta blockers and other medications can help with the sympathoadrenal response. So what about these problems in EDS and joint hypermobility? Well, I started as a general pediatrician running a problems clinic, and we noticed that the patients coming in to see me who had chronic fatigue syndrome typically had lightheadedness, couldn't stand in line, couldn't go to the mall, didn't tolerate a hot shower, and so we did some tilt table tests in them, and we suggested these orthostatic disorders as a cause of chronic fatigue and chronic fatigue syndrome. And along the way, as we saw more and more of these patients, we noticed that we had one or two in the clinic who had a diagnosis of EDS. I wasn't very familiar with that, but when one of the geneticists came and he was looking at a patient of mine who had a low vitamin B12, and he came over and he knocked on the door and he said, "Peter," he's an Irish guy, Michael Garrity, with a good sense of humor. He said, "Peter, you ever actually examine your patients?" And I said, "What are you talking about, Michael?" He said, "This girl's got a papyraceous scar on her leg. She's got EDS, man. Start looking." So we did, and we started using the Beighton score as our screen in the next 100 patients. So these were kids coming in to see me with chronic fatigue syndrome, and over a year period we found 12 with EDS. 6 had the classical type, 6 the hypermobile type, and I think since then we've seen more of the hypermobile folks, but there was a big preponderance of women, and they had a median Beighton score of 7. All 12 had joint dislocations, 3 had surgery. They all had the acrocyanosis I was showing you, and mostly they had localized skin hyperextensibility. Typically they could flip their eyelids inside out, and 6 of the 12 had papyraceous scars. So there was this association then that we were drawing between chronic fatigue syndrome and hypermobility disorders, EDS. They also had the orthostatic intolerance that we see almost universally in those with chronic fatigue syndrome. So in this group, 9 had been diagnosed with hypotension on tilt testing and 10 with POTS. So all 12 had something wrong with them. But not all had lots of syncope. So then we thought, what about the milder end of the spectrum? Do children with chronic fatigue syndrome have a higher prevalence of joint hypermobility without the more complete form of EDS? So we looked at 58 consecutive new patients, 58 who we were seeing already in the clinic, and 58 controls. And the median Beighton scores were much higher in the CFS patients, 4 versus 1 in the controls. And overall, 60% of our chronic fatigue patients had hypermobility. That's pretty extraordinary because that preceded the onset of their fatigue in adolescence. 24% of the healthy children had scores of 4 or higher, and those are your swimmers, your gymnasts, the athletes in school who have an advantage from being flexible but aren't necessarily symptomatic. And this just shows the distribution of the Beighton scores. And the yellow is the healthy patients, 24% of whom had a score of 4 or higher, and you can see that the distribution among the CFS patients is just dramatically different, and this was a highly significant statistical difference as well. Since those observations, others have gone on to make much more sophisticated observations about this problem, and this was a study done in collaboration between Dr. Graham and some Israeli colleagues, including Giris Jacob, who was trained at Vanderbilt in their very good autonomic program. And they looked at 48 consecutive people who had joint hypermobility syndrome and 30 controls, did a questionnaire and some autonomic testing. And in this group as well, the orthostatic intolerance symptoms were much more common in those with joint hypermobility. They had more lightheadedness, syncope, palpitations, fatigue, trouble with concentration, and so on. And in the ones that underwent the orthostatic testing, the orthostatic intolerance was much more common. So 78% versus 10 had orthostatic intolerance reflected in the fact that their standing time, the time that they could tolerate being upright, was much shorter. They also did an interesting study looking at whether there was evidence for true dysautonomia. So they looked at how much isoproterenol needed to be infused to increase the heart rate 15 beats per minute. And so you can see that a much lower dose of isoproterenol was needed to bump up the heart rate in the affected patients, suggesting that they were sensitized to the adrenergic agents. Also, when they were given phenylephrine, it required a much lower dose to bump up blood pressure by 15 beats. So this was 15 millimeters of mercury. So this was an important new advance in this area. Blair Grubb's group in Toledo, Ohio, who have been major contributors about orthostatic intolerance, looked at their patients who had POTS versus the ones who were POTS with hypermobility. And they tended to be, the ones with hypermobility tended to be a bit younger. Almost all of the patients were female, so this was not significantly different. There was more migraine in the hypermobile group, more syncope, and fewer had a viral onset, although the numbers are rather small. The suggestion there being that if you've got this connective tissue disorder, you might have more gradual onset as your vessels get stretchier. And then a really good paper, a series of papers came out of Belgium with a large group of patients, and this is illustrating one of them. They had a series, you won't be able to see it very well, but a series of autonomic function abnormalities, including urinary, GI, pupillary, and sleep dysfunction, as well as orthostatic intolerance. And this compares the hypermobile type EDS patients with the classical type. And you can see that they both have a lot of orthostatic intolerance. The classical type have fewer of these other autonomic symptoms. And here is just the comparison with the controls. And they had very low rates of orthostatic intolerance and very little in the way of other autonomic manifestations. They looked at an orthostatic grading scale, and I just would draw your attention to the thing at the bottom that summarizes a variety of orthostatic measures, and the EDS patients were significantly different than the healthy controls. In addition, when they stood them, this is showing the percent of patients who remain upright, and this is at 5, 10, 15, and 20 minutes. And you can see that the EDS patients were dropping like flies, and by the 20-minute point, only 56% could still be standing. And that's really a remarkable reduction in the ability to be upright, and it would really impair your ability to go shopping, to stand in line at the movies, or any other event. Well, so how are these things connected? We proposed back in 1999 that the connective tissue makeup of the vessels was part of what was involved. That is, when you have this gravitational pooling of blood, the vessels are just more compliant, they can accommodate more blood, you're dumping more blood into the peripheral circulation, and there's less returning to the heart and brain, and then the other symptoms are a consequence. Other theories have been proposed, though. Dr. Benarock at the Mayo Clinic thought, you know, there's a lot of physical inactivity because of the joint problems these patients have. Pain can be disabling, anxiety is a bit worse, and maybe there's a secondary hypersympathetic response triggered by fear of pain on standing. I don't know what Dr. Graham's experience has been, but I've yet to meet a patient who had fear of pain on standing, so I don't give as much credence to this more behavioral explanation. The Gazit group thought that there was evidence of peripheral neuropathy. We don't see that as much in the children, but it may be more common in the adults. Others have wondered about an interaction between the amount of movement you can get in the cervical spine with hypermobile ligaments and dynamic compression of the nerve tissues. And there might be another shared factor, and Dr. Graham mentioned this briefly, but this is this increasing emphasis on mast cell activation disorders. And this was a paper earlier this year from a large group, I think both at the University of Cincinnati and the NIH in Joshua Milner's lab, showing that there was a group of patients that had joint hypermobility elevations in serum tryptase, one of the mast cell byproducts, atopy, and connective tissue problems. And so we don't know all of the connections between these disorders, but these are intriguing. And I think that MUSC had one of the leading experts in mast cell activation problems, Lawrence Afrin, in hematology. So his papers are incredibly useful to look at for the clinical descriptions. Anyway, there may be other factors like this that tie these observations together. Just a final word about the prognosis, because sometimes people think once you have EDS and POTS, you're cooked. There's nothing more you can do, and I want to dispel that belief. So this was a 16-year-old girl who we had seen a couple of years ago. She was a healthy dancer, a very competitive swimmer, starts getting lightheaded at age 12, and her heart rate change was consistent with POTS when we did a tilt test, and blood pressure dropped, and she was pre-syncopal at the 7-minute point. So fairly profound orthostatic intolerance. She was hypermobile. She had blue sclera. She had a positive Gorlin sign, which means you can touch your tongue to the tip of your nose. And she had a thing that the orthopedic surgeons often call snapping scapula syndrome. And overall, her wellness score, her sense of well-being, was only 40 out of 100. So we treated her with physical therapy of a gentle manual sort for about a year. She bumped up her salt and fluid intake. We tried her on different medications to support her circulation. And she gradually improved and then really took off in the summer before she went to college, when she started being able to dance again. She was hiking on the Appalachian Trail. And at college, she started into the ROTC program, and she could do 72 sit-ups in 2 minutes, 38 push-ups in 2 minutes, and a 2-mile run. I'm here to tell you I can do all of those things simultaneously, but she was doing pretty well for a girl. So she was off all of her meds after 2.5 years, and she was able to be approved for the military service. And those of you who can see up close, you know, there's the book, The Hunt for Red October, but there's also the Hunt for Red October fingernail polish, too. So anyway, there is a potential for improvement with these conditions. Not everybody is this fortunate, and we are challenged by the ones who don't do as well. But to conclude, it's pretty clear from what I've said and what you heard from Dr. Graham that females have a much higher prevalence of joint hypermobility and hypermobile EDS than males, that the patients with chronic fatigue syndrome have orthostatic intolerance and an increased prevalence of EDS and joint hypermobility. Those are both, the autonomic dysfunction is more common. The patients with POTS and joint hypermobility present earlier than the ones with POTS alone. And we have some ideas about the mechanisms explaining this, but we really don't know for sure why this connection is there. And I would emphasize that improvement is common and recovery can occur with physiologically based therapies. Sometimes what we read in the literature is that the only thing available, and these are papers from Europe looking at pain and disability, the only thing that the patients should get is cognitive behavioral therapy. I would say that we can do a lot better than that. And then this is just listing the families and foundations that have helped with our work. So I'll stop there.
Any questions for Dr. Rowe?
Good.
Almost escaped. You see the more serious end of the spectrum of patients, and what percentage of those patients need neurosurgery?
We've certainly, I would think out of the last 1,000 patients I've evaluated, probably 70 to 100 have needed some kind of evaluation. We've had a number who had Chiari malformations, congenital cervical stenosis, then the hypermobility leads to early degeneration of the cervical discs. And some of them present with fatigue and orthostatic symptoms long before they have anything wrong on the neurologic exam. That's been quite interesting to follow. I'd probably see you know, the tip of the iceberg phenomenon because it's a referral population, but there's certainly a proportion that need the neurosurgical community to pay attention to these issues, which Dr. Henderson does.
I do have a question. I've worked with physicians who, we have EDS in my family, and different patients that I would see at this particular pain specialist clinic would appear to me that they had EDS. And when I would mention it to the physician or the nurse practitioner, they're afraid of the diagnosis, and they don't know what to do about it if they do say something to the patients. I think the medical community needs some kind of guidance as to if you suspect a patient could have this, what do you do about it? Where do you send the patients? What kind of recommendations do you have? Because they're afraid of the diagnosis, they don't really want to address it with the patients.
I think you raise very good points, and I think people are concerned a little bit about the implications of a label for insurability, among other things, but I think there's a lack of training in the medical schools about this. You know, I didn't know much about EDS. I started learning about it when those patients were showing up in my clinic, and I think we're all in a bit of that same boat. So I think we need better educational efforts in the medical schools and more of these kinds of symposia to help educate our colleagues. I think also better funding of trials so that there can be an evidence base that yes, indeed, these improvements that we see anecdotally do occur. I think when people are confronted with that kind of evidence, it's easy to adopt the new treatments.